Hey everyone, this is going to be part two of our cardiac medications, and what we're going to talk about today is pressors. These are going to be medications that we use in times of cardiogenic shock or decrease in cardiac output. Uh, Most of these medications act on or in a similar manner as the sympathetic nervous system. So, a couple definitions, and these are fairly basic definitions, so I suggest that you go and try to dig a little bit deeper into these. But some basic definitions to get through our talk today are first going to be the word inotrope. Uh, an inotropic effect is an increase in the squeeze or contraction strength of the heart. We also have chronotropic effects, and that would be an increase on the rate of the heart. And these are mostly done by stimulation of the beta 1 cell in the sympathetic nervous system. Vasoconstriction, where we're really familiar with, would be the clamping down of those blood vessels. And this is going to be done in the sympathetic nervous system by stimulation of the alpha 1 receptor. But we'll see with a couple of our medications, we're going to get some vasoconstriction without stimulation of this alpha 1 receptor. But we'll talk about that. So, the first medication that we're going to talk about is epinephrine. So, epi is a hormone, and what epinephrine is going to do is cause some inotropic effects, some really good inotropic effects, some really good chronotropic effects. So we're going to get a good increase in our heart contraction and a good increase in our heart rate. And we're also going to get a little bit of vasoconstriction. There's only one check mark for that box. And epinephrine is, we could say, is going to have a greater impact on beta 1's receptors than it would alpha 1, or an increase in cardiac output with some vasoconstriction. The dose for our epi is going to come in two styles. We have our cardiac arrest dose, which is going to be 1 milligram of our 1 milligram in 10 milliliter concentration. We can also give this as a drip, and we are going to give this as a 1 milligram of our 1 milligram in 1 milliliter concentration. And we're going to add that to 250 milliliters of normal saline. And this is going to give us a concentration of 4 micrograms per milliliter. And we're going to take that and our starting dose for this will be 0.05 micrograms per kilogram per minute. Now, you may see in some references in some books, they won't give these dosages as weight-based. And that's fine. It doesn't mean that it's wrong. Just the weight-based tends to be a little more safer and specific to the patients. So our next medication is going to be norepinephrine. So norepinephrine, unlike epinephrine, is going to have a lot of vasoconstriction with some inotropic and chronotropic effects. Now, norepinephrine is a catecholamine and or a neurotransmitter, and we're going to say that it gives a greater stimulation to the alpha 1 versus the beta 1 receptors, or an increase of vasoconstriction with some increase in cardiac output. Now the dose for this, we're going to start out with 8 milligrams we're going to add that to 250 milliliters of normal saline. And we're going to have a starting dose of 0.03 micrograms per kilogram per minute. Our next medication is dopamine. Dopamine is very common. It's still used widely around the country in many EMS services. Now, dopamine is a little tricky in the sense that we do have dopamine receptors. So we do have dopamine receptors, and we do have dopamine is also a precursor to norepinephrine. So we can also get some alpha and beta stimulation as well. Dopamine is a neurotransmitter, just like norepinephrine. But because of the different abilities dopamine has, we have different effects based on our amount of dosage, or dosage amount. So for a low dose dopamine, we're going to end up stimulating those dopamine receptors, and this is going to cause vasoconstriction, but it's going to be localized. One of those areas that's going to have some localized vasoconstriction is the renal system. And this low dose would be the 1 microgram per kilogram per minute to about 2 or 3 micrograms per kilogram per minute. Our medium dose that's going to have stimulation on our beta 1 receptors. So we're going to get more inotropic and chronotropic effects. The dosage for this, is about 5 micrograms per kilogram per minute to about 10 micrograms per kilogram per minute. Our high dose is going to have stimulation of our alpha 1 receptor, causing that vasoconstriction. And this is going to be that 10 micrograms per kilogram per minute to 20 micrograms per kilogram per minute. So if we go to our little chart, we could probably split this vasoconstriction in half. And we can say that we have some vasoconstriction with our low dose, and that would be localized. And we would also have some vasoconstriction in our high dose. And we would have some inotropic and chronotropic effects with our medium dose. And you could probably assume that most of what we'll see will be in this medium to high range with our patients. All right, the last drug that we're going to talk about is vasopressin. Now, vasopressin was one of our ACLS medications up until the most recent update, and it was used in replacement of epinephrine during our first or second med administration. What vasopressin is a hormone. And vasopressin actually has its own receptors, vasopressin receptors. So giving vasopressin, what that's going to do is activate our vasopressin receptor and doesn't have any stimulation on those alpha or beta. But what stimulation of this this vasopressin receptor is going to do is it's going to cause pure vasoconstriction. And this is going to be done without any effect on cardiac contraction. So if we go to our chart, we'd be very heavy on the vasoconstriction with no inotropic or chronotropic effects. Now, the dose for this, when it was given for cardiac arrest, was 40 units IV push. You may still see this used in the hospital as a drip, for a pressor as well. But I thought that since this was recently used, this may be a medication that you might see in your readings. If you guys have any questions, let me know. Thanks.